Good evening, and welcome to this evening's webinar sponsored by BMT Infonet entitled Treatment Options for Multiple Myeloma, What's Possible Now and What's in the Pipeline. My name is Susan Stewart, and I'm the Executive Director and founder of BMT Infonet, and I'm also a 30-year survivor of an autologous stem cell transplant. BMT Infonet is a not-for-profit patient advocacy organization that provides information and support services to patients before, during, and after transplant. You can view our programs online at bmtinfonet.org or feel free to phone us at 888-597-7674 for a copy. I'd like to thank Celgene, Sanofi Oncology, and Takeda Oncology for their generous support of this evening's webinar. And now it's my pleasure to introduce to you Dr. David Vesole. Dr. Vesole is the director of the Myeloma Program and professor of medicine at Georgetown University. He's also the co-division chief and MedStar Georgetown University Hospital. His research focuses on the management of multiple myeloma, amyloidosis, and Waldenstrom's macroglobulinemia. He has more than 25 years of clinical experience in plasma cell disorders and stem cell transplantation. Dr. Vesole is a member of the Scientific Advisory Board of Blood and Marrow Transplant Information Network, the International Myeloma Foundation, and a member of the International Myeloma Working Group. With that, I'd like to welcome you, Dr. David Vesole, and turn the evening over to you.
Thank you, Sue. It's a pleasure to be here on the night before Halloween, but I don't have any tricks or treats for everyone online. But I do have the opportunity to discuss myeloma, what has been going on over the last few years as far as transplant options and what is new in the future, what's new and exciting regarding upcoming therapies using immune mechanisms to harness usually the patient's own immune system to fight and destroy residual myeloma in individual patients. So it really is a pleasure to be allowed to participate in this webinar for the BMT Infonet. So we're going to start off with some basic premises and basic information so everyone's on the same page. We're going to start off, what is myeloma? I'm showing you a picture here on the right-hand side are myeloma cells in the bone marrow. Let me see if I can make the arrow work. So these guys are the myeloma cells. Not all of them all look the same. This double omelet-looking thing is generally it's a binuclear myeloma cell. All myeloma cells, just like all patients' myelomas, are not created equal. Some myeloma cells look uglier than others, and they actually act that way. In the past, before we had all the new molecular technology, we used to just look through the microscope and kind of have a feeling of how patients would do based on the way the myeloma cells looked. So myeloma is a malignancy of plasma cells. Everyone has plasma cells in their bone marrows. Plasma cells normally make antibody to infectious agents. Any cell in the body can become malignant. When the plasma cells become malignant, we call them myeloma cells. These myeloma cells, because they're pre-programmed to make antibodies, still make antibodies or parts of antibodies when they become malignant, and these are the antibodies that we can measure with various tests to figure out how bad the production of the antibodies are, and when we kill the myeloma cells, the production of the abnormal antibodies decreases over time, and you can measure those with blood tests. Many of you probably have heard of the different antibodies. The most common two are IgG and IgA are the heavy chains. The light chains are either kappa or lambda. It really isn't important which type of antibody your myeloma cells make. It's sort of like your eye color. You have blue eyes, you have brown eyes, you have hazel eyes. Well, you have an IgG kappa myeloma, you have an IgA lambda myeloma. For all practical purposes, they all act and respond the same. These, when they're abnormal proteins, these myeloma proteins, we call it the M protein, and that's what we measure on a test called a serum protein electrophoresis, or when it's done in the urine, we call it a urine protein electrophoresis. I'm going to show you some of the laboratory tests in a little bit. These myeloma cells oftentimes do not directly cause problems, but it's due to cytokine networks or hormone-like networks from the myeloma cells to other parts of the body. For example, as we'll see in just a little bit, approximately 80% of patients with myeloma have problems with their bones. But it's not due directly to the myeloma cells. In our bones, as an example, we have cells that are called osteoclasts. And in my simple version of how I understand that, they're like Pac-Man cells, if people remember Pac-Man. So myeloma cells send a signal to the Pac-Man cells to eat too much bone. If they eat too much bones, they develop holes. Holes cause the bones to get weakened, and then those bones can subsequently fracture and break and cause the symptoms. Similarly, we see low blood counts. It's not because the bone marrow is full of myeloma cells. You can have just a few myeloma cells and yet be profoundly anemic because the myeloma cells use a different network and tell the red cells not to grow, thus becoming anemic. And even though you make too much of one antibody that doesn't work, you don't make enough of the other antibodies, so you have more common problems with infections. So those are some of the manifestations. We're going to see them in a little bit. And this slide here shows, this is a leg bone. For those that don't know, this is the hip up at the top. And inside the bone is where the marrow lives, and this is where the myeloma cells live, not the outside of the bone. So these little kind of upside down or sideways Ys are what an antibody looks like, shown here. This part here, the longer piece, is called the heavy chain, of which there's 5 flavors, if you will, of which in general myeloma patients only have IgG or IgA. And then for reasons I don't know, the light chains are with Greek letters. They're either kappa or lambda. And this is actually the place where you measure the free light chains is on this little piece of the antibody. So these are, again, the myeloma cells. They make these antibodies. The antibodies have no purpose. They're non-functional. Myeloma is not a particularly common disease. It's number 14 of the list of different types of cancers present. There are now, in 2018, it's about the same number. The projected cases are about 30,000, and there's about 105,000 people that have myeloma in the U.S. Myeloma represents only 2% of all cancers. When you look at the average age of a patient with myeloma, the average age is 69 to 70. The number of cases of myeloma keeps increasing over the subsequent years because myeloma is a disease of the older population, and baby boomers, those born from 47 to 64, are all in that 60 to 75 year age range. Thus, there was a big flux of population, and the number of myeloma cases have been increasing by a couple thousand a year. So we already covered some of this, the clinical manifestations. We use this acronym called CRAB. You're going to see this on another slide in a second. So if your Pac-Man cells are eating too much bones, your calcium goes up and you get hypercalcemia. If you get too much calcium in your blood, and sometimes due to the myeloma proteins themselves, you can have problems with your kidney, or R for renal. Anemia we talked about, because the myeloma cells tell the red cells not to grow. And we did talk briefly about bone disease. This is an arm bone, not a leg bone. And in the middle here, you see this kind of black color. That means there's a big hole there, which should be about the same color as up here, higher up on the arm. So this thing has almost no bone left. A patient like this sneezes, burps, moves, tries to open their car door, it can fracture. So we have CRAB for calcium, renal, anemia, and bone disease. And these are the general manifestations of patients with myeloma. That being said, about 10 to 15% of the patients are diagnosed without any symptoms. They don't have CRAB symptoms, but they're found to have an elevated protein in their blood. They're found to have anemia for which they're not symptomatic. They're found to have some problems with their kidneys, but they didn't know it because they don't have any symptoms from mild renal insufficiency. So 10 to 15% of the patients have what we call smoldering myeloma. And those patients generally are not treated except in the setting of a clinical trial. We've improved our outcomes drastically. When I first started doing myeloma back in the 1990s, the average 5-year survival was only 30%. Fortunately, 25 years later, average survivals now are over 50%. And when they look at the next set of data by the government statistics, I anticipate that this number is going to be going up even more. So the survival is markedly better than it was in the past. This is due to better supportive care, the use of bisphosphonates, or the class of drugs that help your bones heal. It's due to better antibiotics, and more often than not, it's due to much better treatments than we had 20-some years ago. One of the questions patients will ask me when they walk into my clinic is, why me? And I don't have an answer for why me. We do know that there are only 2 government-recognized entities that are associated with increased risk of myeloma: Vietnam veterans exposed to Agent Orange, and individuals who worked after the 9/11 disasters that had extensive exposure to 9/11 dust and the like have an increased risk of having myeloma. The rest of the time, other than rare family trees that have increased numbers of individuals with myeloma, for the most part, we do not know what causes myeloma. Myeloma has a categorization. We already talked a little bit about smoldering myeloma. That's when you do have myeloma, you make too much of that bad protein in your blood or your urine, or you have too many of these bad cells, these myeloma cells in your marrow, but you have no CRAB symptoms and you have no symptoms whatsoever. There is a precursor condition, which is common. I've only got it abbreviated here as MGUS, but it stands for monoclonal gammopathy of uncertain significance, which in English means you make a single protein and we don't know why. But rather than spit that all out, we call it MGUS. MGUS is common. As our bodies age, eyes get bad, knees and joints get bad, sometimes our hearts don't work quite as well as they do, or our immune systems also get tired to some degree with age, and sometimes they make a protein that they shouldn't make, an antibody they shouldn't make, but it means absolutely nothing. It's just part of probably the aging process. The incidence of MGUS, this benign pre-malignant condition, is about 3.5% of all 50-year-olds. And when you get to 80-year-olds, and most people will say there's not a whole lot of 80-year-olds in the country, but if you think of all the 80-year-olds in the country, if we actually tested them, about 10% of all 80-year-olds would have this pre-myeloma condition that's benign. These patients do need to be followed because a small percentage of them will eventually go either to smoldering myeloma or myeloma that requires treatment. There's some new criteria for diagnosing myeloma that was changed about 4 years ago. If you have more than 60% of these abnormal cells in your marrow, if you're free light chains, remember that's part of the antibody molecule, the ratio is more than 100, or if you have 1 or more lesions on an MRI or a CT, then you should have myeloma even though you don't have any symptoms with any of these 3 criteria. So what are the typical lab tests? We covered some of these already. A protein electrophoresis, this tells you how much myeloma you have in your blood or your urine. Chemistry panels are necessary to look at your kidney function. Blood counts are essential so you can look and see if you're anemic. These free light chains are another test to see how much myeloma you have. Everyone needs a bone marrow as much as one to test the idea. Doesn't like to have the procedure done, but you need it for A, you have to have it to absolutely diagnose the disease, and B, more importantly, is that's the way we find out your risk factors, and that the genetic makeup of the myeloma cells can only be determined at this day and age by a bone marrow. In the future, we may be able to do some of the same testing with blood samples, not ready for prime time yet. And imaging, skeletal surveys, the typical test, but skeletal surveys were traditional tests to look to see if you had bone lesions, but they're kind of like looking at black and white TVs, which probably no one on the conference call has a black and white TV anymore. So more sophisticated tests, MRIs, CTs, or PET CTs, give you much more information and should be done in select situations. Staging, I'm going to give you 2 slides with staging on it. One of them is fairly simple, the other one's a little less simple. The staging system originally was based on how much myeloma you had in your body. It was called the Dury-Salmon staging system. For the old-timers on the line, they'll probably remember they have a Dury-Salmon 1, 2, or 3. Myeloma doctors are not very intelligent. We only have 3 stages, whereas almost every other cancer has 4. But that staging system wasn't very accurate, particularly because of the bone problems. And the number of bone lesions you have is not necessarily correlated to how bad the myeloma is. It's just a measure of how active those Pac-Man cells are. But there are 2 blood tests. One's called a beta-2 microglobulin, and the other one is albumin. And these are markers of disease activity. So based on your beta-2 microglobulin or albumin, you get placed into stage 1, 2, or 3. This staging system was first published in 2005. What this staging system didn't take into account was the importance of genetic abnormalities in your myeloma cells. So 10 years later, the International Myeloma Working Group came up with a revised international staging system. So this is the original one of 1, 2, or 3 based on the beta-2 microglobulin and the albumin. But with the revised one, we included LDH, which is an enzyme that is increased in people that have aggressive myeloma, and it included some of the genetic risk factors, deletion of chromosome 17, a trading, if you will, of material between chromosomes 4 and 14, or a transfer of material between 14 and 16. So instead of just using the 2 beta-2 microglobulin albumin, we now include the LDH and the genetic abnormalities, and we came up with a revised staging system. Why is this important? And not to judge any individual who's on the line, but stage 1 patients, which is the least aggressive form of myeloma, have lifespans that we think exceed 10 to 15 years on average. Everyone's different. That's important for everyone to know. Whereas the patients who have stage 3 disease have a much worse prognosis. So that's one staging system. The Mayo Clinic, there's 3 Mayo Clinics in Rochester, Minnesota, Jacksonville, Florida, and in Scottsdale, Arizona. Between the 3 Mayo Clinics, there's about 35 doctors who do myeloma. They have this thing called mSMART. You can get this online. It's called mSMART.org. And on that, you can actually get a lot of information about how to manage myeloma and information about myeloma per the Mayo Clinic. Not to say that this is all-encompassing, but these are consensus opinions. And the Mayo Clinic recently changed they had 3 categories. They had a high risk, intermediate risk, and standard risk. And they decided to ditch the intermediate risk group and just divide it to high risk and standard risk. And in their categorization, there's additional cytogenetic abnormalities that are considered poor prognostic features. Interestingly, not all genetic abnormalities are considered to be unfavorable. There's some that actually are in the standard risk group. So there's a group of genetic abnormalities that are high risk, that's associated with the ISS stage 3. There are gene expression profiles that you can have done commercially now that can give you more information about the DNA to categorize how severe and how aggressive the myeloma may be. So one of the other questions that patients ask me is, not besides what the treatment's going to be, is can I be cured? And in general, we don't use the cure word very leisurely. And one of the reasons we don't use that term very leisurely is shown as an example on this slide. When I was in training, we used to say myeloma was one disease, one clone, one disease. We now know that there are 8 to 12 myelomas at the same time within any individual. And these myelomas can change over time. So what this is supposed to be showing you, all these different colored dots, is this is the original myeloma clone, if you will, this blue dot. And over time, you see some other clones that have developed. Here's a green clone, here's a red clone. So ultimately, the patient needs to be treated. We treat the red clone. We may eradicate the red clone. But look, some of these other clones are oblivious to that. Some of the other clones, or new clones, can develop. Here's a yellow clone that was never seen before. Here's a combination of yellow and red clone, and so forth. The myeloma keeps mutating and evolving over time. We're constantly chasing our tails to try to eradicate the clone that's active at any moment in time. And this is one of the main issues of why we're not able to routinely cure this disease. The other issue we have is we don't really know for sure what the grandpa or grandma clone of myeloma that starts the whole process looks like. Because ideally, you'd like to kill this cell, not these cells down here. But we don't know for sure at this point in time what this cell looks like, so we can generate specific therapy to eradicate the myeloma stem cell. So myeloma is very complex. If you have acute leukemia, which I wouldn't wish on anyone, but if you have acute leukemia, you're either in remission or you're not in remission. It's very, very simple. If you have lymphoma, you can be in a partial remission or you can be in a complete remission. So there's two choices. Look at the choices that you have with myeloma. There's complete remission, there's stringent complete remission, there's very good remission, there's partial remission, there's stable disease, and there's patients who are getting worse. And this is not the whole story, and there's different criteria how we decide which category you fit into. So for example, stringent complete remission, I'm not going to go over all these. You have no protein that we can measure in the blood or the urine. A more sensitive test than that SPEP or UPEP is called immunofixation. It's negative. Your bone marrow, we don't see any abnormalities by looking at the microscope, by staining the cells, and we also have a normal free light chain assay. If you meet all of this, you have a stringent complete remission. So we used to think that was the best way to go. That was the best response you can get. But we now have measures that can look for a thing called minimal residual disease. Minimal residual disease is, if you think of a complete remission as 100 points on a test, a stringent complete remission is 110 points on a 100-point test. Minimal residual disease is like getting 125 points on a 100-point test. So this is tumor burden. This is a iceberg. We only see the top of the iceberg originally, which is like 10 billion cells. When patients get complete remission, we're down to 10 to the 8th cells, which is still a lot of cells. Stringent complete remission is another level lower. We can find out there's more sensitive technology by either painting the cells or doing DNA sequencing that can get you down to 1 to the 4th cells, and hopefully over time we can get down to 0 and actually hit the bottom of the iceberg, and patients will truly be cured. Does this matter clinically? So MRD, this minimal residual disease, and when you see these plots like this, these are called Kaplan-Meier survival curve plots. The line on top is the one that does the best. So the line on top here is a patient who has favorable genetics, the favorable stage, and is MRD negative. They've got 125 points on the test, and their likelihood of staying in remission is up here. When you look at the halfway point, it's about 4 years that they stay in remission. When you look at how long they survive, this group of patients has not reached the average survival, and they're out over 8 years. So that's in contrast to people that have bad genetics and are MRD positive after treatment. They have a fairly dismal outcome. So the MRD is associated with improved remission duration and improved survival. That's kind of background. We're going to talk about treatments before I get off schedule here. MGUS we watch. Smoldering myeloma we talked about. This is when you actually have myeloma and have no symptoms. They are observed unless they're a candidate for a clinical trial. And in active myeloma, we need treatment. And treatment is a variety of different treatment options, which can cover some of them, plus you need supportive care for people to maintain healthy bones. So over the last 15 years, we've had 11 new drugs. 11 new drugs shown over here. In a disease that's rare, myeloma has actually had more drugs approved for the number of cases than any other disease. And the number of drugs that are forthcoming in the next couple of years, there's at least 2 more drugs that may be available within the next 2 years. One of them, I think, may be approved next month. So when you look at treatment, because we have all these drugs, you get initial therapy, and if you're considered to be a transplant-eligible candidate, you're young enough, you're in good enough health, you have adequate organ function, we do a transplant for consolidation is recommended and considered standard of care. Most individuals also go on maintenance therapy. Ultimately, if you're not cured, the disease may come back and then you have to be treated again. And we're going to cover some of that as well. If you're not considered a transplant candidate, you get your initial therapy, and for the most part, you stay on that therapy. Unfortunately, for the people on the phone listening in, the standard of care for myeloma in the 2018 is once you start a treatment, you never stop it. And there's data to support that concept. So in general, principles of therapy, we usually give triplets for people who are either candidates for transplant or not candidates for transplant. The most common triplet in the U.S. is, I'll give you the trade names, not the generic names. Revlimid, Velcade, dexamethasone is the most common triplet used. There are some individuals who like to use Cytoxan, Velcade, dexamethasone. We usually reserve this in our practice for patients who have kidney problems. But the up-and-coming regimen that is not approved yet for initial therapy is Kyprolis, Revlimid, dexamethasone, or KRD. For patients who are not candidates for 3 drugs, they're too ill, they have kidney problems, they have heart problems, then we often give doublets of either Revlimid Dex or Velcade Dex. And then maintenance therapy, at least in 2018, which could change in the very near future, is generally considered to be Revlimid. Although there are some people with high-risk disease that we give doublets of Revlimid and bortezomib, or Velcade, or Revlimid and Ninlaro, which is an oral proteasome inhibitor. Why do we do transplants? Well, we give high doses of a drug called melphalan. Melphalan is indiscriminate in what it kills in the bone marrow. It kills good cells as well as bad cells. It's a good thing it kills the bad cells. It's not a good thing it kills the good cells. So we have to rescue the patient from the chemotherapy by giving them back stem cells so their bone marrows grow again. This is essential for the proper recovery of your bone marrow after the high doses of the melphalan. So it's really a rescue operation to allow us to use melphalan. The most common type of transplant is autologous, using your own cells. Investigational studies are still undergoing using donor cells or allogeneic cells. Almost everyone who has an autologous transplant gets peripheral blood. When I first started doing transplants, we used bone marrow. Almost never do we use bone marrow anymore. And now, for those who do have donor transplants, you can use, although they're extremely rare, umbilical cords. When we look at transplants, the vast majority of people get a single transplant. Some patients get 2 transplants, 2 autologous transplants. And there are certainly clinical trials of doing autologous followed by a donor transplant. How do we do a transplant? We collect the stem cells, the bone marrow-like cells from the bloodstream. We hook you up to a blood processing machine. We collect the stem cells. We put them in the freezer. When the patient's ready to come in for the transplant, they get their high-dose chemotherapy, which if you use melphalan, which is the standard of care worldwide, takes 30 to 60 minutes. 24 to 48 hours after that, we take the stem cells we've collected, we thaw them in a water bath, we infuse them back into the blood. They have little homing devices, and it takes 10 to 12 days for those cells to grow, thus the 14-day period for the transplant. Chemotherapy takes 1 day, 24 to 48 hours after the cells are infused, and then it takes them 10 to 12 days to grow. There are a variety of ways to collect stem cells. Again, we don't use bone marrow. We can give growth factors. The growth factors that you may be aware of are Neupogen or some of the newer formulations of Neupogen, Zarcio or Granix. And sometimes we use a drug called Mosavil, which helps Neupogen. These stimulate the bone marrow to make more stem cells that fall into the bloodstream so we can collect them. There are ways to collect even more cells or juicier number of cells by giving chemotherapy regimens with the growth factors, and some of the centers use that combination of chemotherapy with the white cell growth factors. So the question we're going to raise right now is transplant needed? Why would I pose that question? These are some of the more recent regimens. RVD we talked about. This was the Kyprolis Revdex. And if you look at the likelihood of getting a VGPR, to remind you, VGPR means 90% reduction of the bad protein. Look at this. RVD and KRD, almost 100% of the patients respond, and almost 80% of the patients go into a very good partial remission. So if you get such good responses without a transplant, why subject an individual to 2 weeks, loss of hair, and all the potential side effects from the transplant procedure? So in the past, using old drugs that we don't use anymore, they found that transplant was superior to non-transplant. So to ask the question whether we still need transplants, there's a U.S.-French trial. Part of it's been published, the other part isn't quite ready yet, where they looked at new therapies, RVD or VRD, and in this trial, patients got 3 cycles of VRD, everyone got their stem cells collected, half the patients did not have a transplant, half the patients did have a transplant. Both groups got more RVD consolidation, and both groups went on to maintenance therapy with Revlimid. In the group that did not get the transplant initially, they were to get the transplant later when they relapsed. What was the results of this trial? When you had a transplant early, you stayed in remission for an average of 50 months versus 36 months if you didn't have the transplant early. Now, I should point out that even though that there's a 14-month difference in how long you stayed in remission, at the time this study was analyzed, it's too early to see if one group actually lives longer than the other group. So transplant early provides longer remission. This is another look at the same data with longer follow-up. Again, the line on the top is the line that does best, and the line on the top with longer follow-up again shows that the transplant group had an improved remission duration versus those who did not have the transplant. What about the likelihood of getting that 125 points on that 100-point test? If you had a transplant, the green line up here shows that the likelihood of getting that MRD negativity was substantially better for those patients who did not have the transplant, and you stayed in remission longer. And this is another one, the likelihood of getting MRD negativity. That previous one was how long you stayed in remission. This is the likelihood of getting MRD negativity was 80% in one group, 65% in the other group. And for those individuals who are listening who are not interested in transplant, I want to be fair and equal to all. If you became MRD negative, these two lines are the same. The yellowish line is the group that had the transplant. The dark line is the group that did not have the transplant. If you were MRD negative, you did the same, but the likelihood of being MRD negative was higher in the group that had the transplant. So what do we do with that information? Well, this is a trial that's ongoing right now. You get induction therapy, you get checked to see if you are MRD negative. If you're MRD negative, you get randomized to either an early transplant or late transplant. If you're MRD positive, you get more induction therapy until you're MRD negative, and then you get a transplant. So we're trying to find out if you need the transplant if you're MRD negative, to do a large trial to look at that exact concept. We don't want to put patients through a transplant unless they need it. Maintenance therapy. Why do we do maintenance therapy? Well, the reason to do maintenance therapy is to prevent and prolong your remission, to change if you weren't in a complete response or you were not MRD negative, to try to convert you, and ultimately we want to improve how long you live. So this is data from a recent trial from Europe, from the UK. They looked at maintenance therapy versus no maintenance therapy. The group that had the maintenance therapy had much longer remission duration, from 30 months without maintenance therapy to 57 months with maintenance therapy. This same exact numbers were true on an older study done in the US, almost identical duration of remission with and without maintenance therapy. In this particular trial, that was true regardless of your genetic risk. The other trials did not show that. So all the trials, there's 3 trials, I only showed you one, show that you stay in remission. Progression-free survival is how long you stay in remission if you go on maintenance. Only one of the trials so far has shown that you live longer, even though you stay in remission longer. But there's always a downside. Long-term Revlimid can cause problems with your bone marrow. You can have low blood counts. There is a risk of getting a second cancer. It's 3 to 4% if you go on Revlimid. And there's always, the most important thing is, if you're going to be alive and be in remission, what's your quality of life, comparing maintenance to no maintenance, and we don't have that data yet. And then, as some of you probably know, if you have large copays and you're going to be on this drug, if you're going to be on Revlimid for up to 5 years, it could be very costly over time. I should tell you, because I don't have a slide, that there is, at the upcoming National American Society of Hematology meetings, they're going to show you, there's going to be data shown of essentially oral Velcade, it's called Ninlaro, versus observation, similar to the trial I just showed you, and they sent out a press release. We already know that the Ninlaro had an improved remission duration compared to observation. So we now may have not only one drug, Revlimid, but also Ninlaro that can improve remission duration. And just as an aside, in the future there's going to be combinations of both those to see if we can improve it even more. So before we go on to new therapies, I just want to conclude that autologous transplant, standard of care worldwide. Using consolidation after transplant is considered. There's data from Europe that says this is beneficial, data from the US that doesn't agree with that, and maintenance therapy is considered standard of care. We can get deeper responses when you give very potent regimens. This KRD may or may not be stronger than VRD with a transplant. Early transplant is superior to late transplant. That's still the standard of care. Allogeneic or donor transplants may be curative, but they come at a much higher risk and remains investigational at this time. Drugs. We have a lot of drugs. Most people have heard, and I apologize, these are the generic terms for the drugs. Revlimid, Pomalyst. There's 2 new drugs that are cousins of Revlimid and Pomalyst in clinical trials that look very, very encouraging. We talked about Velcade, Kyprolis, and Ninlaro. There's another 2 oral drugs in that class, probably not going to be ready for prime time. They have different side effect profiles. There's a variety of drugs that look very promising that attack the cells by a different mechanism called kinase inhibitors. The next drug that probably is going to get approved for myeloma is a drug called selinexor. It's in front of the FDA right now. This information should be forthcoming in the fairly near future. Venetoclax is approved for chronic lymphocytic leukemia, has some very nice activity in myeloma. And this particular drug, which I can't even pronounce, was devised specifically for patients who had that 17p deletion. So they're giving this drug with Velcade in patients with 17p. and the preliminary results look encouraging. There's a class of drugs called HDAC inhibitors, canabinostats 1, ricalinostats 1, and avarinostats 1. But the ones that are the most exciting are the monoclonal antibodies and immunotherapies, which I'm going to spend the rest of my time. So just so you know, when disease comes back, you've got all these different regimens that are possible. I'm not going to read them out, but these drugs across the top are all FDA approved as individual drugs or in combination, and look at all the combinations that people can get to treat their myeloma. We are really blessed and that with this number of combinations, and these are effective combinations. So what happens when what other combinations can we do? So monoclonal antibodies are proteins that target specific markers on the myeloma cells, which we're going to spend a lot of time on. We can give immunomodulatory drugs, checkpoint inhibitors, which can try to break down the way that tumor cells hide from the immune system to try to stop them from hiding. Vaccines, which are very encouraging in some diseases, are still being actively pursued to try to boost your own immune system to fight the myeloma. And one thing that's the most exciting aspect right now are these things called CAR T cells. We're going to go over that in a little bit more detail in a moment. Monoclonal antibodies are directed against the surface of myeloma cells. So if you think of myeloma cells as having houses on them, you may have a brown house, you may have a white house, you may have a blue house, you may have a green house. Monoclonal antibodies can be directed against specific houses. So Darzalex, daratumumab, is an agent that attacks the White House. So it only attacks the White House, and there's not White Houses on very many cells besides myeloma cells. Very few other cells in the body have white houses on them, predominantly in myeloma cells. So this drug is now approved for initial treatment, it's approved for relapse treatment, and being studied for maintenance therapy. It's not convenient. It's intravenous. The first dose of the drug takes 8 to 9 hours, and even after 3 or 4 weeks of the drug, it still takes about 3.5 to 4 hours. What's in the future? They're going to be able to give this drug over 3 to 5 minutes by an infusion subcutaneously into your fat. So this is, in studies, very, very promising, is equally efficacious as the IV form. Infusion reactions can occur almost only with the very first time it gets administered, which is why it takes so long the first time. 40 to 50% of the patients will have infusion reactions. When the data with the sub-Q, it's about 10%. So not only is this faster, it's safer if we get the sub-Q, not going to be approved anytime in the next year. There's different kinds of monoclonal antibodies. There are those that are naked. You can have them connected to a chemotherapy drug that we call drug conjugates, so you can attach an antibody to a drug, so the antibody can attach to the myeloma cell, and attached to the antibody is a drug that can be injected right into the cell. Or you can have an antibody that attaches to 2 cells. So this particular antibody, this bispecific antibody, attacks, in this particular case, it's a red house on the surface. This is the antibody here. It's attacking the red house on the surface. But look, there's another part of the antibody that brings in your immune cells. So this antibody has 2 prongs with, if you will. It's got 2 forks on both ends. On both ends, one of the forks is stuck into your immune cells. The end of the fork is stuck into your myeloma cell. So you can bring your own immune cells in close proximity to the myeloma cells so they can work better. So you can do this with drugs. You can do this with bispecific antibodies. All of these are in clinical trials. And because of time-specific, these are a variety of different bispecific antibodies in clinical trials. Data is very sparse right now. I'm anticipating in our national meetings in December, we're going to hear a lot more about bispecific antibodies. And again, so I can allow time for questions, I want to move ahead. I want to talk about CAR T cells. This is a CAR T cell. CAR T cells are your own immune cells, We take them out of your body. The next slide is going to show you a cartoon of how this is done. We take them out of your body and we call up our engineers, and the engineers are going to construct those cells, and they're going to do two things by engineering them. One is they're going to make them angry. They're going to put genes in these cells to make the cells angry. And the second thing they're going to do is they're going to arm these angry cells with missiles. So we're going to take one of your normal immune cells, put it in culture, genetically engineer it to make it angry, and give it missiles to attack your own myeloma. This is shown schematically here. They hook you up to a blood processing machine. You just get hooked up. You don't get growth factors. You don't get chemotherapy. They just hook you up to the machine. They take out your immune cells called T cells. We add this genetically engineered information into the culture, and these genetically engineered cells will grow. We take them, infuse them back into your arm. They go to the tumors, they go to your bone marrow, they go throughout your body, and they do their dirty work to kill myeloma. So what are the data with this? I only want to show you there's 5 different types of CAR T cells shown on this slide. I don't want to go over all the specifics. I want to talk about just one, not to be preferential. I want to talk about just one because it's the one that was presented most recently at our national meetings. It's called the Bluebird study. They actually presented 44 patients in the actual trial. They had 94% of the patients. Again, there's no chemotherapy. We're just giving these angry arm cells back to you. 94% of the patients had a response. Almost 60% of them went into complete remission. This is all fantastic information. For no chemotherapy, these patients were very heavily treated. They had an average of 7 types of prior chemotherapy regimens. This does come at some price. These cells, when they're all juiced up, they do interesting things to your body because they're angry arm cells, and you can have reactions to them that we call cytokine release syndrome. It's rarely severe. Grade 3 or 4 means how severe it is. It's only 10%, but it's fairly common to have some type of response. The most common thing is fever. Goes away after a few days, it's done. Interestingly, and they don't know how this works, you can have some neurologic side effects from these cells as well. Again, it's not permanent. And when you look at these other constructs, the other trials, some of them do not have any neurologic side effects. So these are different ways to make CAR T cells. You know, one's a Lamborghini, one's a Maserati, one's a Rolls Royce. There's different ways to make these CAR T cells, and they don't all have the same outcomes. So these CAR T cells are very exciting. They have very, very good response rates, unbelievable response rates, including complete remissions. What's not shown on this slide is that we're still not sure how long they last. In this particular trial, again, it's not a very long follow-up, but the average time people stayed in remission was about 11 months. Not 11 years, 11 months. So we still don't have, this is a process that's ongoing to try to improve the outcomes. So where are we going with CAR T cells? There's a current trial called the KARMA trial that is hopefully, if it's a positive trial, will be sent to the FDA to see if this can't be approved and be available outside of clinical trials. Right now, the only way you can get a CAR T cell is through a clinical trial. This particular trial is at 19 sites, but there are over 20 different CAR T cell companies. And not only that, within even one company, there are multiple different ways they're making CAR T cells. We still don't know how they work, and we don't know why they stop working. And we're trying to get even better CAR T cells that last longer and have better missiles. We're trying to find ways to decrease this risk of this toxicity, this cytokine release syndrome that can cause fevers and a variety of other symptoms, including nerve problems. And one way to do that is to put a switch in it that if you start having problems like that, you give them a drug, turns on the switch, the cells die. And in the future, this process of making those CAR T cells I showed you previously, that I showed you here, this takes about 4 weeks of time. Ideally, we'd like to have a mechanism where we can get the CAR cells faster. Some of the patients can't wait 4 weeks. And one way to do that is to generate these cells from other donors that would be specific for an individual's CAR T cell, but made specific for an individual's myeloma cell, but can be made in the laboratory for anybody. Also, very little information on that. So we're all excited about CAR T cells. Don't know when they're going to be approved. I would tend to think for those who are interested, it's not going to happen until the end of next year. The only way you can get CAR T cells right now is on a clinical trial. We still know long-term outcomes of these clinical trials. We don't have hardly any individuals that are out more than 2 years. We don't know outcomes beyond 2 years. There's a variety of different ways. I told you right now we're using the most common target is this greenhouse, but we may need to find out that you need to attack the red house or the blue house, not the greenhouse, to come up with the best target for the missiles, or missiles that can attack both green and blue houses. Those are all in process. And then we talked about drugs, or the antibodies that are attached to drugs, the antibodies that are attached to bring in other cells from the immune system, and maybe that'll be a better way to go, or maybe combination of the CAR T cells and the antibodies may be the way to go. And with that, I am going to finish and open the forum to questions and answers.
Thank you, Dr. Vesole. That was a very clear and very informative presentation about the options for treatment for people who have multiple myeloma. We're now going to open the forum again. So the first question, Dr. Vesole, comes from Valerie. She wants to know what are the two IMIDs that may be up for approval.
So these two, the CC220 and 122, they're in phase 1 clinical trials. So just so you have an idea, these drugs are 3 to 5 years away from being FDA approved. They're very early in the clinical trial process. They look very promising, but nothing moves that fast for drug approval. I can't imagine less than 3 to 5 years.
All right, Robert would like to know what are the lab values that indicate a return to active multiple myeloma disease in a patient who has had an autologous stem cell transplant?
So in general, we monitor individuals first, second, third month after a transplant, and then every 3 months after that. The 75% of the individuals will have an increase in that protein, that M protein in their blood or urine as the first manifestation that their disease is back. 25%, the rest of them, may show some other tests besides that protein increase. They may show some evidence of anemia. They may show some new bone disease. They may show some problems with their kidneys. But the vast majority of individuals, the first sign of it coming back is slow increase in the abnormal myeloma proteins.
Robert would like to know what, if any, is the advantage of a tandem stem cell transplant?
That's a great question. I wish I had a great answer. There's an old study, when I mean old study, 1994 study that was published in 2003 that showed two transplants was better than one, particularly in those patients who did not achieve this very good partial remission. But 1994, we had none of these drugs that are listed on this slide right now. To bring it up to date, there were 2 trials that were done, one done in the U.S., one done in Europe, using modern therapies. They had completely opposite outcomes. In Europe, they showed that 2 transplants was superior to 1 transplant. In the U.S., they showed that 2 transplants was equivalent to 1 transplant. There's differences between the two trials. We're still not absolutely certain how you can explain the dichotomous difference between the two trials, but currently most of the transplant centers do not routinely perform two transplants. We usually reserve it for specific indications. That being said, almost all transplant centers will collect enough stem cells to complete two transplants in case we want to do one in the future. The exception to that statement is that Medicare will only pay for a single transplant. So I can't give you a good answer of 2 versus 1. We do 2 transplants in the concept of a clinical trial.
Jack would like to know whether checkpoint inhibitors are dead.
Are dead? Jack wants to know that. I'm willing to guess that if he asks that question, he knows the answer. Checkpoint inhibitors are a very, very important class of drugs. For those of you who are not familiar with that class of drugs, everyone knows Jimmy Carter, the president, who had melanoma, and he had melanoma that went to his brain. Checkpoint inhibitors are what potentially cured him. It's a different class of drugs. Due to time, I don't want to go over how they work, but they're very, very important in a number of solid tumors and actually in lymphoma as well, particularly Hodgkin's lymphoma. Checkpoint inhibitors in myeloma have been tested fairly vigorously in combination with either Revlimid or Pomalyst in large clinical trials, and in those large clinical trials, they showed no advantage of giving checkpoint inhibitors in myeloma with those combinations, and not only that, the group that got the checkpoint inhibitors had more side effects. So checkpoint inhibitors right now are not dead, but they're being limited to very few patients in clinical trials, and I don't foresee them becoming popular anytime soon, potentially down the road as maintenance therapy or in combination with other drugs, but as far as active treatment for active myeloma, I don't see it happening anytime soon.
Catherine would like to know if there's any data to show a specific kind of treatment that is more effective with 1q plus or 13q deletions.
So 13q deletions are not considered high risk. If I can go back to my slide, I'll show you the Mayo Clinic one. 13q deletions are present in over half the patients with myeloma using current technology. So you don't see 13q on this list, and it's not part of the staging system. The 1q is on this list. It's not in the staging system. The 1q, to the best of my knowledge, there is no specific targeted therapy for 1q at this time. The only specific targeted therapy we have that are in clinical trials are for 17p. And this one, the p53 mutation. There is no drug specifically designed right now for the other abnormalities listed here.
Okay, Robert would like to know post-transplant, starting at M protein of 0.2 GDL, increasing by 0.1 GDL per month. When do you change the treatment?
So I didn't give the definitions, or maybe I did give you the definitions for progressive disease. So this is the definition of progressive disease, of when you should definitely consider changing treatment. That's when you have an increase of the M protein, the bad protein, by 25%. But what's not listed here is it has to be a minimum of 0.5 grams per liter. So if it went from 0.1, if that was the lowest point, it'd have to go to 0.6 before it would be considered progressive disease and think about changing treatment. And myeloma.
Vanitha would like to know why skin rashes and hives happen due to thalidomide.
Skin rashes and hives. Can happen with Revlimid, Pomalyst, or thalidomide. There are probably about 20% of the patients can have reactions. I don't think we have an absolute mechanism of how that occurs. It's usually, I won't say never, but almost never serious, almost always, just with withdrawing the drug, whether it's Revlimid, Pomalyst, or Thalidomide, the rash will go away. And the truth of the matter is that once the rash resolves and you re-challenge the individual, about 80% of the time they don't have recurrence of the rash. Only about 20% of the time do you have recurrence of the rash, but even then it's usually managed reasonably well with other ways to control the rash. And very few patients truly cannot take one of those three drugs because of true allergies manifested as a rash.
Donald would like to know, after BMT, how long do you stay on Revlimid maintenance? He has good IgD and good blood work.
So in the U.S., which is, I assume everyone is on the phone from the U.S.
Not necessarily.
The standard, not necessarily. The standard of care is to continue it indefinitely. In France, you only get it for a year, and in Spain, you get it for 2 years. And there's actually a trial. The trial I showed you briefly. Let me see if I can find it. This trial here, where it says 18 months, it's a mistake on this. The slide's wrong. This trial is being done in the U.S. and France. In France, they completed the trial. They gave a year of maintenance therapy. The U.S. is doing this same exact trial as shown here, except where it says 18 months, which was 12 months in France. It's going to be for 3 years. And they're going to be able to answer whether you need 1 year or 3 years, and they're going to let the people at 3 years stay on the drug if they want. But in the U.S., the standard of care is indefinite.
Okay, we have another person who says, CAR-T is very exciting and gives me a lot of hope. Are there any trials exploring the impact on younger, earlier stage myeloma patients? Waiting until 7+ lines of treatment and a beat-up immune system seems counterproductive. Could better results be produced by CAR-T using it earlier in the diagnosis?
So the very simple answer, because there's more questions, is yes. There's currently a trial for, I think, first relapse, where patients are going to get either CAR T cells or one of 3 conventional regimens for treatment, moving it way up faster, or I should say earlier, to answer that exact question.
Rika would like to know whether patients who have had an allogeneic stem cell transplant are eligible to get CAR-T.
None of the CAR T cell trials that I'm aware of allow allogeneic transplant patients on them currently. Whether that'll change in the future is likely, but the answer currently, to the best of my knowledge, is no. There is no CAR T cell right now that allows allogeneic transplants.
Kathleen would like to know whether the treatment for multiple myeloma is also used in the treatment of amyloidosis as well.
The treatments are almost in parallel, except the difference is that in amyloid we're not giving consolidation and we're not giving maintenance therapy. The disease burden in amyloid is much lower, and most people could stay in remission for an extended period of time. The symptoms and the organ involvement with amyloid can be much more problematic than it is with myeloma, but if they respond, they actually have very nice outcomes. But same regimens can be used for both, including transplant, which is standard of care for individuals who are considered transplant candidates.
Bob would like to know how important second opinions are for people with, to quote him, plain vanilla myeloma.
I think everyone should see a specialist, but that's because I am one.
All right. Willie would like to know if there are any problems with creatinine supplements in multiple myeloma.
I'm not sure what a creatinine supplement is, but the bottom line is if it doesn't hurt you, most people would say if you want to do it, you're supporting the health food stores.
Douglas would like to know, is there a standard interval between the end of induction therapy and the harvest and transplant?
So the old standard was 4 to 6 cycles, but that was based on regimens that aren't as potent as some of the ones we use currently. So most people can probably get by with 3 to 4 cycles and then proceed to stem cell harvest. There's going to be myeloma guidelines coming out probably by the end of the year from the American Society of Clinical Oncology. It's going to be published in Journal of Clinical Oncology, where they're going to say 2 to 4 cycles. I believe it says 3 to 4. I'm on the committee. It says 3 to 4 cycles of induction therapy, whereas traditionally people said 4 to 6. You probably don't need that many with the potent induction regimens we use now.
Marcia would like to know why it's important to use dexamethasone with myeloma drugs.
So dexamethasone, the bane to almost everyone, not everyone, because there's some patients who really like dexamethasone. Dexamethasone has really good anti-myeloma activities. If you give high doses of dexamethasone by itself, you can get a 40% response rate. And as it turns out, when you give dexamethasone with other drugs such as Revlimid, Pomalyst, Velcade, Kyprolis, you get a situation where 1 plus 1 equals 3, not 1 plus 1 equals 2, because they actually interact positively together to get you a better result than they would be individually.
Steve would like to know whether there's an advantage to get Velcade in the abdomen versus the leg. He's had stronger adverse reactions in the abdomen than the leg.
So no, it's just a localized phenomenon. What I should like to point out is I'm hoping that no one on the line is still getting IV Velcade. IV Velcade is approved, but causes substantially more neuropathy than the injections. And the fallback for that is even if you have neuropathy from Velcade, the Ninlaro, the oral type version of Velcade, causes almost no neuropathy. You can stay within the same class and still benefit from it and not be as concerned about developing neuropathy.
Okay. Catherine says, I heard that there may be some promising results from quad therapy for initial treatment, DARA plus VRD or DARA plus KRD. Can you speak to that? So
DARA plus VMP is already approved. Quad therapy is already approved for frontline therapy. So VMP is Velcade, melphalan, oral melphalan, not the melphalan we use, IV melphalan we use for transplant, and prednisone. Essentially, no one in this country uses VMP. It's inferior to the regimens we use, which would be RD or KRD. So right now, it's daratumumab's already approved for frontline. There are ongoing studies of DARA KRD, DARA VRD. The same thing's true for the other monoclonal antibody. It's a different target that attacks the gray houses, if you will, on myeloma called Amplicity or elotuzumab. Also is being utilized in quad formulations with VRD.
Steve would like to know how difficult it is to get accepted into an immune trial, DARA, etc. What would be the criteria for acceptance? He had a severe reaction to either Velcade or Revlimid last year and is currently on DARA waiting for a transplant. Would he qualify for a trial?
So essentially, clinical trials are only eligible for individuals who are progressing. If he's in remission on daratumumab, he's not going to be eligible for a clinical trial. And the likelihood of getting clinical trials is you have to find a center that is close enough that has something you'd be eligible for to enroll. You know, we talked about CAR T cells. Everyone wants a CAR T cell, but it's very, very difficult to get on the CAR T cell trials. They're still in the early phases. They're limited in number of patients. They're limited in the number of institutions that have the CAR T cell technology. So it's hard at this point in time to get on those trials. There are different organizations that can and websites that can help you find clinical trials. One of the easiest ones is clinicaltrials.gov, which you can search for clinical trials and see what's there and where they're located. But that even when you do that doesn't mean you're eligible, and even if you're eligible doesn't mean they have a slot for you. it's not an easy situation to get on the high-profile clinical.
Beverly has a two-part question. She wants to know if there's vitamins she should avoid taking while she has multiple myeloma, and what your feeling is on using marijuana while you have this disease.
To the best of my knowledge, there's no studies that show marijuana has a positive or negative effect in myeloma. So I don't think you're going to get any myeloma. But whether it's a good supportive care measure is up to the individual. Vitamins, the only thing I'd recommend if we're talking vitamins is that if you're on Velcade or Kyprolis or Ninlaro, you shouldn't take vitamin C or drink green tea the day you get those drugs, because it can limit the efficacy of those drugs. So vitamin C and green tea are no-nos on days of Velcade, Ninlaro, or Kyprolis.
We'll take a few more questions. We're getting towards the end of our. Catherine would like to know what kind of lab tests should be done for those with smoldering multiple myeloma and how frequently they should be done.
So the lab tests are the same for smoldering myeloma, and the frequency really depends on the type of protein, the number of marrow myeloma cells, and how high the protein is in either the M protein or the free light chains. And it can vary from 3 months to 6 months to a year. But they have to be monitored indefinitely. The risk of evolving into myeloma from smoldering disease that requires treatment is 10% a year. So it's cumulative, though. It's 10% the first year, 20% the second year, 30% the fourth year, and so forth. Once you've hit the 5-year mark, actually the risk goes down to 5 to 3% a year. So it really depends on the level and the, how comfortable the oncologist is in spreading out the frequency of the test.
Julie would like to know why researchers don't routinely break down and report results separately for high-risk versus low-risk patients.
The high-risk patients have a poorer outcome. We're still trying to find a better mousetrap and try to improve that group of patients. We've improved the outcomes for the standard risk patients by almost 4-fold over the last 20 years. We have not improved maybe 2-fold for the high-risk patients. So there's a substantial difference in how much improvement we've accomplished in the standard risk versus the high risk, and we keep trying to improve the outcome in those patients so that everyone will live long and fruitful lives with good quality of life.
And then I think this will need to be our last question, unfortunately. We've got a lot of questions left, but we're running out of time. James noted that on the RISS staging slide, translocation of 414 had an asterisk in the right high-risk category. Can you explain this, and what is the best maintenance plan after transplant?
So 414 is definitely considered still to be in the high-risk group by the ISS. I'm trying to pull it up for you. 1 second. Okay, I had it working before. The scroll. No, it's not scrolling. Not that critical. The 414, unlike the other genetic abnormalities, appears to be somewhat sensitive to that class of drugs that Velcade's in, Velcade, Kyprolis, and Ninlaro. So for those particular patients, my personal preference is if they have a transplant is to put them, even though I've told you the Revlimid is the standard of care, I generally put them on Ninlaro and Revlimid, even though Ninlaro is not approved for that indication yet, because I want to give them the benefit of attacking their myeloma twofold. One is the standard myeloma mechanism with maintenance with Revlimid, and then Ninlaro to particularly help the group of the cells that have the 414 translocation. But it is a group that class of drugs has changed from high risk to a lower level of high risk, if you will.
All right, and with that, unfortunately, I think we need to bring the webinar to a close. I want to thank Dr. Vesole for an excellent presentation and an excellent Q&A session for you. Again, if you have any questions or need help, you can phone us at 888-597-7674. And once again, many thanks to Celgene, Sanofi, and Takeda Oncology for generously supporting this webinar. Everyone have a wonderful evening and good night.